Okay, and we're live. So welcome everyone to today's webinar Wednesday, where we're looking at the disparities in the US healthcare systems, focusing on the opioid epidemic in the US. My name is Katie Terry. I'm one of the moderators today and in all of our webinars. I will be passing off in a moment. Just a quick reminder of, when you have questions, go ahead and put them in the chat. We're going to address them during the Q&A at the end. Please feel free to use that chat function to ask any of those questions, and we'll address them to the panelists. I'll be on the back end here if you have any other questions or if you have any technical difficulties. But for now, I'm going to pass it off to our moderator today. She is one of our health management and informatics PhD students, so Rachel Twitter.
Thank you so much, Katie. Hi, everyone. Nice to meet you, and thank you for joining us again for this webinar Wednesday. With me, I have three panelists. I have Dr. Barbara Andraka-Christou, I have Dr. Andre Koval, and I have Andre Bailey, the CEO of Change Everything. If I can ask you all one by one to please say a brief introduction and a statement about yourself and your endeavors. Dr. Basha Andraka-Christou, could you please start?
Hi, yes, thanks for inviting me. I am a faculty member in health management informatics. I also have a joint secondary appointment in internal medicine, and my research focuses on health policies and health service related issues for medications that treat opioid use disorder, as well as person-centered care for people who have substance use disorder.
Thank you. Dr. Koval?
Hello, everyone. My name is Andre Koval. I am the assistant professor in the same department, health management and informatics. My background is in quantitative methods. I'm a quantitative psychologist by training, but the last 6 years I've been working in applied projects related to healthcare. So two of my postdocs took place in Canada. I worked with Vancouver Island Health Authority and Center for Disease Control of British Columbia, understanding public data sets and trajectories of patients across time, specifically in terms of the health services that they consume over the course of their patient career. My research involves working with data closely, so I consider myself a data scientist because I do a lot of predictive analytics and explanatory analytics, and I work with data on a daily basis. And I specifically enjoy working on data visualizations. As you'll see from today, this is my the thing that gets me excited in the morning is to create a new graph or interesting information display. So that's me.
Thank you, Dr. Koval. Andre?
Hi, I'm Andre Bailey. I am the founder and CEO of Change Everything. Change Everything is a nonprofit social innovation company that works to address some of society's most important issues, including poverty, homelessness, and the mental health and addiction overdose crisis through various what we would not call publicly, but privately, for those who understand this world, collective impact models, that Stanford University model that we kind of do our own way. We believe at Change Everything that in American society, America is fascinating. We really are a country of, hundreds of millions of people that act and live our lives, spend our time, spend our money, create our policies based on what we believe. So Change Everything is really about getting powerful groups of leaders, many times business leaders, faith leaders, philanthropic leaders, other folks who aren't involved in these social issues and sometimes have the wrong idea about them. Our job is to get them into coalitions, help change the way they think about those issues, and then turn them on those issues to make change, real change. And the only way that our work is effective is if we see those issues transformed. So that's what I do, and I'm excited to be here.
Great. Thank you so much for that introduction, panelists. With that, let's go ahead and get started. Dr. Andraka-Christou will be leading us off speaking about medications for opioid use disorder in the COVID-19 era.
Great, thank you. You can click on the next slide. So before I get started, just a couple of acknowledgements here, funders of the research and also collaborators in Project ECHO. I will mention just briefly, if you've never heard of Project ECHO, it's all around the US. I'm a subject matter expert for the one at Arizona State. It's a model that uses existing medical professionals to train other existing medical professionals in whatever field those medical professionals want to enter. So we specifically focus on training existing physicians like primary care doctors in medications for treating addiction. And they contributed to this presentation. Next slide. So why are we talking about medications for opioid use disorder? Why is this a topic? Obviously, there is an overdose crisis going on involving opioids, although now also more and more types of medications as well. We're seeing upticks across the United States in methamphetamine use and cocaine use and alcohol use disorder, but still in terms of the death rate from drug overdoses, the primary factor is opioids. So that's why we're talking about opioids. Now, for opioid use disorder, to prevent it, to treat it, there's a lot of different approaches. But when you look at the studies, the most effective approach for treating opioid use disorder is medications that people take either on a daily or monthly basis. And those medications help prevent cravings, in some cases help prevent withdrawal symptoms, and just generally stabilize the brain, allowing them to function and focus on their day-to-day activities. So don't take my word for it. It is considered the gold standard, these medications, according to such renowned organizations as the American Society of Addiction Medicine, the World Health Organization, SAMHSA, government agency, NIDA, another government agency. And in the last couple of years, there's been a concerted policy push at the federal and the state levels to expand access to these medications. Up to 50% decreases in overdose deaths are associated with people who take the agonist versions of the medications, meaning methadone and buprenorphine. And I'll talk about those medications and their differences and mechanisms in a moment. But I just want to pause on this note. That's a really, really big decrease in a death rate, right? That's not a typical thing you usually see in medicine, such a dramatic decrease. So just a reminder, this is a really important topic because it's such an effective tool. And then the other thing is that when you compare these medications to other treatments out there, it's not that the other treatments are bad or worthless or useless. It's just that on balance, the medications have a greater protective factor against overdose. So at the minimum, they should be used and perhaps also for some individuals in combination with other tools like counseling, especially if they have some pre-existing conditions, mental health conditions that contribute to their opioid use disorder. Next slide. So I'm going to briefly touch on 3 medications, and then after that, I'm going to move into talking a little bit about policies that are affecting access to these medications at the federal level. I was hoping to get to some of the state level policies since that's some of the research I do, but I'm going to not have time for that today, but I'll at least give you a taste for some of the federal policies and then changes that are occurring to those federal policies in light of the COVID epidemic or pandemic. So medications for opioid use disorder can be grouped into 3 categories: methadone, buprenorphine, naltrexone. These are the generic names. Methadone is a full agonist, buprenorphine is a partial agonist, and naltrexone is a full antagonist. I'll go into what those things mean, but I just want to specify right here that their mechanism of action, the way they work on the brain, are slightly different. So these are substitutes. A patient could choose between the 3 of these medications. They all work on certain opioid receptors in the brain that are called MOUD receptors. So every mammal has opioid receptors. We actually have lots of different kinds of opioid receptors. And in particular, one kind called the MOUD receptors are responsible when they are activated for releasing dopamine, and dopamine makes you feel good. And if you feel good enough and you get a strong memory associated with that in your brain, then you're going to start using the opiate or the medication or what have you that's affecting that receptor over and over again. So part of the idea here with these medications is that we're targeting these receptors because these receptors themselves are ultimately related to you feeling good. Next slide. Here I'm going to show you briefly in a graph the difference between these 3 medications. So you have these receptors in the brain, the MOUD receptors. All of these medications target it in some way. But what exactly happens when they're targeted? So let's start with methadone. Methadone's a full agonist. It means it's fully activating those receptors. By fully activating them, it's stopping cravings, it's stopping withdrawal symptoms. But as you can see, the line goes up. And the line continues going up with the dose going up, right? So at some point, you may overactivate the receptor too much, which could lead to respiratory depression. So there is a risk with methadone. Partial agonist buprenorphine actually will flatten out. I'm not sure why it's missing from the graph. Sorry about that. I think maybe because there's a dark background. It should actually flatten out at a certain dosage at around 24 milligrams. It'll go up and then it'll just become flat. And so what that means is it's going to activate the mu receptors partially, but then eventually it's just going to stop activating them. And the reason I mention that is even though it's activating those receptors that are responsible for your feel-good chemicals in the brain, it's not going to activate them too much to the point that you're going to have potentially an overdose. So with that in mind, buprenorphine is a little bit safer than methadone. And then lastly, you have naltrexone, which is an antagonist. So it doesn't activate the mu receptor at all. It actually just literally blocks the receptor. Next slide. So as I mentioned, methadone is a full agonist. So what does this mean? And just to give you, I'm not going to go too much in depth here, but to explain the differences between the medications. So because it's fully activating the receptors, it's helping with the cravings and it's helping with the withdrawal symptoms. It also has what's called a medium binding affinity. And what that means is if you try to put another opioid in the receptor, it's probably not going to get in the receptor. So let's say I give you heroin after you took methadone, because methadone has this binding affinity, it's like latched on really tightly to that receptor. The heroin, unless it's at a really high dosage, or maybe you're not taking an appropriate dosage of methadone, chances are the heroin's not going to attach. You're not going to feel an effect from the heroin. So that's one of the benefits here of methadone. So yes, there is a risk that you could take too much, which could lead to an overdose, but on balance, it's very effective and actually leads to decreases in overdose because we're preventing cravings and withdrawals. So you don't want to take heroin to begin with. And then even if you do take the heroin, the methadone is already bound so tightly to that receptor that the heroin's not getting in. Obviously, I'm kind of oversimplifying things, but just, big picture. Next slide. Buprenorphine is a partial agonist. It actually has a really high binding affinity, even more so than methadone. Once buprenorphine latches onto that receptor, essentially nothing will kick it off. It's even more tightly bound than methadone and also than heroin and other opioids out there. So it's very good at blocking a high. At the same time, it only has a partial agonist effect, meaning it's only partially activating that receptor in the brain. So as I mentioned on a previous slide, you're unlikely to have an overdose, even if you take a ton of buprenorphine, you just went crazy. And that's really good. And that's what I mean by the ceiling effect. At some point, the effect from another dose is going to reach a ceiling. It's going to plateau. People who take buprenorphine who have never had an opioid in their lives before could feel a little bit of euphoria because it's releasing dopamine ultimately into their brains. On the other hand, if they're already opioid dependent, they've been taking heroin regularly, let's say, and then they take buprenorphine, they are really probably not going to feel anything. That's what the studies show. So there are sometimes concerns of, oh, well, what if we get too much buprenorphine floating around on the street? Again, if it's, a child picks it up, they've never had an opioid, yeah, they could get really sick. But someone who has a very serious condition of opioid use disorder is unlikely to feel any euphoric effect from the buprenorphine. Like methadone, it prevents the cravings and the withdrawal symptoms. Unlike methadone, you have to do a partial detoxification first. And why is that? It's because that really high binding affinity that's there, if you have some other opioid already in the system, it's going to kick it off. And when it kicks it off, what does that mean to you? It means you're going to go into precipitated withdrawals. And it's a fancy term for a very uncomfortable condition of flu-like symptoms and just feeling very, very sick. So, that's not a great way to start someone on treatment, right? By giving them like the worst flu of their lives. So instead, people who are starting this treatment are told to do a partial detox, usually about 72 hours. Next slide. All right, and then the last medication is very different from the first two. Those are agonists. This one is a full antagonist. Anta is in like against. So it actually blocks the receptor. It doesn't activate it at all. If anything, it's like an off switch, whereas the other two are an on switch, methadone being like all the way on, buprenorphine partially on, naltrexone is you're totally blocking the switch. So it blocks the mu receptor. very high binding affinity. So it's going to block any other opioids that try to get onto it, heroin, methadone, buprenorphine. Really important thing to note here is it does not reduce withdrawal symptoms. And part of the reason for that is because it's not actually activating that receptor, it's just blocking it. With that in mind, because it doesn't reduce withdrawal symptoms and also it has that really high affinity, just like buprenorphine, you have to detoxify first, but you actually need to do a complete detox before you start naltrexone, or else you're going to get those precipitated withdrawals. Why does this matter? Why do I even say it? It's a really big barrier to starting treatment, right? You can think of barriers to these medications as like an onion. There's so many layers. There's legal barriers, stigma barriers, health service barriers, not enough trained individuals in the workforce and so forth. But there's also just the factual matter that for something like naltrexone, you need to do a 7 to 14 day detox first. And detox is very uncomfortable. You probably aren't going to be successful if you don't go into a detox center. There's too few of them. They're super expensive, especially if you don't have insurance. So you can already start to see how this may be a very hard thing for a patient to get on, even though it's effective. In terms of the cravings, it does seem to affect cravings, although it's unclear why. It's not actually affecting that receptor. It's not releasing any dopamine, right? So, we don't really understand why there's an effect on cravings. It may be psychological more than anything, just knowing that you can't get high if you have this medication because that receptor is being blocked, that naltrexone is binding so tightly to it that the heroin's not getting in. So maybe just the knowledge of that fact is making people have lower cravings, because it's like, why even think about it? Anyways, unclear at this point. We don't really know why there's an effect on cravings, but there seems to be some effect. Next slide. So recent federal policy changes, and I have a lot here on the slides. I'll try to break it down. As I mentioned very briefly, I wrote literally an entire book on how these barriers exist and have populated and are layered on top of each other. This is just one of many barriers, and it's the policy barrier and specifically the federal policy barrier. I'm trying to show you in this slide, as well as in the next slide, how the policies have changed a little bit in light of COVID. COVID has been very interesting in the policy world for these medications. So let's start with methadone. The slide's on methadone. So where can you get methadone? Under federal law back to the 1970s, you can only get methadone in an opioid treatment program, which is also often called a methadone clinic. Has that changed at all in light of COVID? No, you still can only get it in a methadone clinic. I will flag here the very interesting and bizarre point that you can get methadone for pain management at a different dose and frequency from any doctor anytime, as long as they have a DEA ability to prescribe controlled substances. But when it comes to getting it for addiction treatment, you have to go to this very special clinic. Very few are available. Some states only have like 2 clinics in the entire state. So obviously big access barrier. What about induction? That means your first time you're getting methadone, you're starting to get methadone. They're titrating the dose to figure out what's the right dose. The rule previously was that this had to be in person only. So as opposed to, like, let's say you get an antibiotic, you just go pick it up at the pharmacy, bring it to your house, take it yourself. For methadone, you can't do that. They have to in person administer it to you and watch how you're doing in the event, let's say, that you have some negative reaction. This is a very serious medicine. So that hasn't changed, but again, could potentially be an access barrier. You can't just pick it up from the pharmacy and go home. All right, then the next thing, and this is where the federal law changed dramatically, and there's been a lot of talk about this. I've been interviewed myself about it. It's just fascinating. So it used to be the case that you rarely could take methadone home from the clinic. You had to actually, not just for induction for starting it, but every day there and after, you had to go to the clinic to get your methadone. They had to physically administer it to you, typically in a cup. You drink it. They say to you, what's your name? And you say your name out loud so they can see you actually swallowed it, and you leave. And you would do that every morning before work, let's say. Well, obviously getting in line with 1,000 people every morning is not a good approach during a pandemic. That's a wonderful way to spread COVID-19. So the federal government in March instituted the first changes of this kind since the 1970s, that you can actually immediately get up to 2 weeks of a take home. So you still have to do that first one, the induction in person, but now you can get 2 weeks to take home and take in the comfort of your own home if you're what's considered a less stable patient. And the law is very unclear about what that really means. It's very much in the discretion of the medical director at the clinic. And you can get up to an entire month home if you are considered stable. So contrast that to prior to COVID-19, the law that was in effect for about 40 years. Prior to COVID-19, you would only at the minimum be able to get 2 weeks after a year. And that was only after meeting some, very specific conditions that the medical director had to sign off on. Like, you've been coming to the clinic regularly, no positive urine drug screens, no criminal activity, et cetera. And then to get an entire month to take home, you had to wait 2 years. So this is a huge, huge change, right? So a lot of us on the policy side are just absolutely fascinated to see what is the implication of these policy changes? How is this going to affect utilization of the medications? How is it going to affect overdose rates? How is it going to affect poisonings? I mean, just so many things for researchers to be diving into right now. Sorry, that induction is repeated. Then medication management. So it used to be that if you wanted to go and talk about your side effects, have the follow-up, kind of a typical follow-up like you might imagine when you have any health condition you get a medication for, you had to do it again in person. Now the law is saying that telehealth can be used for this purpose. So again, that's a really important change. And why is that? We don't want people coming into the clinic and passing COVID-19 amongst themselves. The only limitation here is that if there's a dosage change to the methadone, you still have to come in person for that change. Then on also the telehealth side, so counseling, it's not that it was forbidden by law to do it via telemedicine before, but it just wasn't really reimbursed. CMS did not have policies designed that were set to facilitate reimbursement of telecounseling. And now that is the case. So why does that matter? For methadone, when it's provided in these opioid treatment programs, people in order to get their methadone are required under both federal and state laws to appear a certain number of times per month and even per week at first in order to do counseling. Well, again, pandemic time, not a great idea to have 20 people huddled in a room doing their counseling. So that's why we care about this shift in the policy to allowing payment for the telehealth counseling. And then lastly, what about the software, right? So you might ask yourself, a lot of people who have opioid use disorder or any substance use disorder are low income. They might not have a wonderful computer system. They may not have the internet. How are they going to do this counseling? How are they going to have their follow-up for the medication managed? So we also have had the federal government say across the board, not just for methadone clinics, that you no longer, well, let me phrase it this way. Technically, you still need HIPAA compliant software, but that they are exercising their discretion to not enforce the requirement of HIPAA compliant software. So at this point, really essentially the word on the street from the government is go ahead and use non-HIPAA compliant software as long as it's not public facing. So, not like YouTube, not TikTok, right? But you could do just an audio telephone call from your cell phone. You could do Zoom, for example. Next slide. So this slide's a little shorter. Buprenorphine, slightly fewer policy changes, but still some important ones here. So buprenorphine, again, I was telling you previously about the ceiling effect. You're less likely to have a risk of an overdose with buprenorphine than methadone if you were to take too much. And the reason I even gave you that information is so you can see why that relates to the policy. You have fewer restrictions when it comes to buprenorphine because it's a slightly safer medicine, right? So it's regulated less heavily, but it's still regulated quite heavily, with that said. So where can you access it? How can you get it? So you can get buprenorphine in several different ways. You could go to an opioid treatment program, just like you can go for methadone. But as I mentioned before, some states have hardly any opioid treatment programs. So that's not a fabulous access point, right? So starting in 2000 or 2002, when buprenorphine was approved, there was a big shift to federal law that said specifically for buprenorphine, just your regular doctor in their doctor's office can prescribe this to you. Your primary care doctor, your psychiatrist, your OBGYN, you no longer have to go to an OTP. Has that changed? No. So that's still the case since 2002. However, the bad news, I would say, with that law in 2002 was that your doctor can't just have their medical license. They also have to go above and beyond that in order to prescribe buprenorphine. They have to get something called a DEX waiver. So to prescribe any controlled substance, you need a DEA waiver. If you want to prescribe buprenorphine, you have to go a step beyond that and get a letter X next to the DEA waiver on the DEA's big list of doctors. And to get that waiver, most physicians, or in this day and age, nurse practitioners and physician assistants, are going to need to do some extra training, go do 8 hours of continuing medical education courses, serve in a NIDA-sponsored clinical trial, or there's some other mechanisms to get this education. And so that can serve as a barrier. So did that change in light of COVID? No. Why do I bring it up? Because it's really been talked about a lot lately, right? We know from many studies that this DEA X waiver requirement is a barrier. It prevents sufficient physicians from prescribing buprenorphine because they don't have the credential to begin to do it at all. So, there has been hope, there has been discussion, maybe now finally after 18 years, the federal government will axe this X waiver. They've not done so. Okay, what about induction? This is where we have seen the big change. So it used to be that for buprenorphine and really any controlled substance, you had to have your initial induction of it have an in-person visit associated with that prescription. So you could not just, call in a prescription for buprenorphine and someone go pick it up at the pharmacy if that's their first prescription. They had to physically come in, have the appointment, see you, and then after that, the next couple of times they could just go to CVS and get the prescription. Well, again, the federal government is aware that we shouldn't be having too many people go in and out of doctors' offices these days. Let's try to keep people home. So a big change that occurred back in March was SAMHSA and the DEA saying that buprenorphine no longer needs that induction. So what that means in practice is that even if you've never seen the physician in person, all you have had before is a telemedicine phone call appointment, they can at that point already prescribe it for you to pick up from the pharmacy. So why does this matter? Again, very low income population often. Transportation may be an issue. You also don't really have that many physicians, NPs, PAs who have a DAX waiver. So even if you have transportation, your nearest one might be in the next county. So every time you have to go in person to do something, even for that induction, it's just another barrier. So again, an area researchers are heavily looking into. I work on 2 teams at the RAND Corporation that are really diving into this right now. We're looking at how utilization of these prescriptions has changed, how picking up of the prescriptions has changed, if at all, because of this COVID policy change. And we expect that, probably there has been a change, maybe even an uptick, because in theory, it should be easier for you to get your medication now. Just like for methadone, the medication management can now be via telehealth. The telehealth counseling is being reimbursed. Why does that matter for buprenorphine? Under some states' laws, not all states, but some states actually require that buprenorphine prescribers ensure that their patients are going to counseling as well. And then just like on the methadone side for telehealth software, you no longer have to, well, again, officially you have to have it be HIPAA compliant, but the federal government is not going to enforce it. They're using their discretion to ignore it if it's not HIPAA compliant. So those are the big changes. There are, I'll just really briefly say, I don't have a slide on it anymore. The states themselves have the option to implement these changes. They're not forced to do so. What we're seeing in our study is that most states are choosing to implement these changes. So they are choosing to have the maximum flexibility that is being afforded to them by the federal government right now. And so that's really exciting. And people who study policy in this area have just a lot of work to do this year. And I think that's all I've got.
Thank you so much, Dr. Andraka Christou. Dr. Koval, would you like to introduce your person-centered care and SUD presentation?
I would. However, I think Dr. Andraka Christou will do a much better job of that. So let me introduce, say a few words how I got involved in this project, and I'll hand over to Basha to do the introduction of the first 2 slides. So I'm a applied statistician. And a few months ago, Basha said, well, we have this interesting survey that we administered to a bunch of staff working in substance use treatment facilities, but there's so much data, we don't know what to do with this. We need some way to represent this information in a way that it would make sense, both to the funders who funded this report and to us, so we can put it into research publication. So the background is we have a quite substantial survey that was administered to a number of facilities. There was initially 10 or 12 facilities, but some had to be excluded. So let's go to the next slide and let Basha do the intro to this one, and I'll take over when the graphs start.
Great, thank you. Yeah, just really briefly, so the focus of the project is on operationalization of person-centered care in substance use disorder. So person-centered care, hopefully you all have heard this term, but it can be conceptualized in many different ways. Usually a conceptualization of it includes something like individualizing care to meet the specific patient's needs, providing holistic care that looks at the whole person as opposed to, only treating the person as a disease. But again, just to reiterate, there's many different inconsistent conceptualizations. For purposes of our project, we picked one that is used and recommended by the Institute of Medicine / the Picker Commonwealth Foundation. And according to that conceptualization of person-centered care has 8 different dimensions. And the goal for our project here, as I mentioned, is to operationalize these dimensions, each of these 8 dimensions specifically in the substance use disorder context. So why is that? Person-centered care is a very conceptual thing right now. It's really kind of a pie in the sky, idealistic concept. Respect patient preferences. Okay, well, how do you do that? How do you actually do that in practice? How do you put pen to paper? So that's what we mean by operationalization. How do you take these conceptual ideas and then actually put them into practice? So the goal of this project was to figure out how can you do that across these 8 dimensions that are listed here. I won't read them all. And specifically in the substance use disorder context, which we think is important and unique because person-centered care has really not been a hot topic in substance use disorder until pretty recently. It's really late to the game. And part of the reason for that is it's been historically very paternalistic, very coercive. A lot of people are forced into substance use disorder treatment by family members, the criminal justice system, so forth. So, it's really, in some ways, it's kind of an awkward fit even historically for substance use disorder. But we believe, our team believes this is really important and it's time for it to move into this field. But again, how do we actually do it? How do we operationalize it? Next slide. So briefly, and then I'll pass it to Andre. So what were our methods? This is an exploratory mixed method study, 2 stages. First stage was qualitative data collection and analysis. The goal here was to come up with a list of potential practices for operationalizing person-centered care in each of those 8 dimensions. We came up with that list by doing semi-structured interviews with staff and patients from one of the managing entities, the South Florida Behavioral Health Network in South Florida, Miami-Dade area. And once we collected that data, we did a thematic analysis across and within each dimension to identify what are those actions that can be taken for operationalization. After that stage was completed, we moved into a quantitative data collection and analysis stage. And this stage involves taking the results from the first step, from the qualitative step, using them to develop a survey, and then fielding that survey across staff who work in substance use disorder treatment facilities at SFBHN, at that managing entity. Now, the goal of the survey was to identify relative frequencies of types of operationalization. So in step 1, we're saying, how can you even do it? What are the ways you can operationalize it? In step 2, we're saying, are there certain ways that are more or less common among these ways that we have identified? Next slide. And I'll pass it off to Andre here.
All right, so let's dig in and see what we found. These are still preliminary results. The sample that was analyzed and is being presented has data from 6 agencies. We operationalized the agency. It must have at least 1 administrator reporting, and it must serve non-incarcerated individuals. So from those corporations that provide these services, only 6 were collected. And what you see on your screen is the number of respondents per each corporation. So we get an idea of who's reporting on whose data is being presented. So we have to replace the names of the treatment centers to protect the privacy. But Foxtrot has 19 and Alpha has 1 people responding to that survey. Next slide, please. So here's the breakdown by the type of the role of the respondents in this corporation. There was more than that, but we categorized it into broad 4 categories. So administrators are the primary interest because they're probably most knowledgeable about the what's going on in the corporation. They're shown in red. So Foxtrot has 4, while Alpha and Charlie have 2. Bravo and Delta, Charlie and Alpha 1, Bravo and Delta 2, and Eco 3. The next group is treatment providers, variety of treatment providers. You see that Alpha and Bravo do not have any other respondents but the administrators. And treatment providers would include such categories as a mental health counselor, a nurse, or a substance use counselor. Next category is case managers and recovery support technicians, such people as advocates or behavioral health technician or recovery support specialists. So now that we know who was responding to the survey and who provides the data, let's look at the questions that were asked and the responses that were provided. So let's zoom in on the first corporation, Eco. We'll have only the time to look at several ones, so I'm selecting the ones that have the most respondents. So you see 2 graphs. Let's look at the first graph titled Item Score. So on the y-axis, you see the list of the questions on the survey. They are broken down into different domains that we conceptualized as sort of fitting together. So for instance, the first domain, peer group, asks 3 questions, and they ask to what degree certain practices are being implemented in that category. So do people have to attend a peer group? Can they choose something besides a 12-step? Is it even something available besides the 12-step? So that's an example of a domain. So each domain would have a set of questions, and the people were asked, respondents were asked to rate the practice of this or rate the implementation of the practice on the scale from 1 to 5, where 5 indicates that, well, this practice is practiced often, and 1 not very often. So some of the questions were recoded. So for to ease our interpretation, the higher the score, the more patient-centered this corporation is, or in this particular dimension is. So we see that there are 6 different domains: peer group, represented by blue, deep blue; language, represented by violet; diversity, maroon or raspberry; treatment, coral; counseling, the largest domain, containing 8 questions, in orange; and everything else that we didn't feel were really related to fitting into any other domains, which is grouped as other. So the length of the bar, and we're talking about administrators reporting for this corporation. The length of the bar relates to the friendliness in terms of patient-centeredness in that corporation with respect to that practice. The 3 columns before on the left of the bar graph represent some additional information that we want to have at our disposal when we interpret this graph. So the number in black represents the number of respondents. As you've seen in the previous graph, it varies drastically from 1 to 19 across the corporation. So we want to remember how many respondents were responsible for that pattern. The larger, the more trustworthy that result is. The number in red is an index that we called a red flag. So whenever a person responds in the extreme, so like are interpreters available? I'm sorry, let's choose a different way. Does the person have to attend peer group? If the respondent says always, that's the most extreme response, and that sort of sends a red flag because the choices of the patient is being restricted. So we want to be aware when such extreme policies are implemented or treatments are applied. So that's the number in red, sort of red. I made it colorblind friendly, so this is we'll call it red. And green, the number green represents the number of green flags. So whenever somebody says responds with an extreme positive or in terms of patient-centeredness, we put a green flag to it so that we know what areas are doing good and what areas are doing well, what areas are doing not so well. So that's the graph on the left. The graph on the right represents the entire, so we summarize the entire survey and just report the score for that domain specifically. And we just unweighted mean. So basically one item contributes a single score to that to the peer group. So that 2.8 mean of the peer group domain score is basically an average of 1.7 and 4.0. So that's just a way to capture the overall trend. So for this organization, for this corporation, when administrators are reporting, what patterns do we see? Well, we see that language and diversity are the highest in terms of patient-centeredness. Peer group as well. Counseling has the worst score. So administrators perceive or report the counseling having the least amount of friendliness in terms of patient-centeredness. Well, this is administrators. Part of what we're trying to understand in this project is how those perceptions or reports differ according to the role that people play in the corporation. So if we go to the next slide, we'll see all the non-administrators, how they report the situation. And if we start oscillating between the two, you'll start picking up the differences. So first, focus on diversity, for example. We see that administrators rank the diversity of their organization much more positively, as well as peer group. And that's the pattern that we see everywhere. The overall administrators report or perceive their corporations to be more patient-centered friendly than non-administrators, but not on every aspect. If you focus on counseling, for example, we'll see that administrators actually report lower scores on counseling than non-administrator. We think it's because those people who actually involved in counseling view it more positive. If you're involved, if we have a lot of counselors responding, well, yeah, they're doing it day to day, so they would probably be biased to report as more patient-centered than administrator who might be removed from the delivery of care. So that's an eco corporation. Let's go to the next set of slides and look at the foxtrot and also oscillate between the administrators and the non-administrators. We'll see a very similar pattern. We see that language and diversity being higher for administrators than non-administrators. And overall, administrators report a more positive view of the patient-centeredness for their administration, for their corporation. The next slide, let's go to the next slide and pause. This is this summary for all the corporations that we're reporting on. Focusing on administrators. Again, the interpretation of the numbers to the left of the slide is slightly different. They just report the number of items that were responded with at least one red flag. So that's a different metric just to understand how a particular domain might be of interest. But looking across the corporations, what is remarkable is that the similarity of this pattern across corporations. We see high marks on language and diversity and somewhat peer group, and consistently low marks on counseling and treatment. And that if we start oscillating between administrators and the total group, so like this is all rows including the administrators, we also see this this pattern. We see that administrators view services generally more positive than not administrators, but not when it comes to the delivery of care, and specifically the counseling. So that's our early reports, early results. And I would like to see if Basha has any comments on that, if I got everything.
Yeah, thank you so much. I actually haven't seen this visualization of the data yet, and I just think it's fantastic. Great work. Wow. I'm so thrilled, and I can't wait for it to put this up in an article. You know, one thing that I was thinking about is, you know, why, the answer to why, right? So why are we seeing these patterns? And I just wanted to propose a potential reason with respect to the diversity language versus counseling. And I'm just wondering if maybe it's somehow easier from an administrative standpoint, perhaps, to implement some of the things that we consider to be operationalizing language as opposed to operationalizing counseling. Like maybe there's just more of a barrier to implementing some things. The other thing that comes to mind is on the administrator versus provider side, are administrators somehow biased, you know, because they're seeing it from a higher level perspective and they're not seeing the nitty gritty of how counseling's actually occurring or how treatment's occurring? You know, is there something maybe more rosy when your look is from the top down versus being in the weeds, as it were, as a counselor? So, you know, just something I'm really looking forward to diving into more deeply now that I see these results, just trying to think about why we're seeing what we're seeing.
Great commentary. Thank you so much, Dr. Koval, for your presentation. All right, Andre, if we could, we'd love to hear about Project Opioid next.
You're mute.
Andre, you may be muted.
Didn't even realize it. So thank you guys for all the information you got that was just shared. Excellent data. And I'll get through my slides quickly. I know we only have a few minutes left. Go to the next slide, please. So, you know, you heard the data shared by these real experts, and I want to reiterate, just experts on the opioid addiction crisis. And I think I put these stats up there just to emphasize again how absolutely ridiculous the opioid crisis is. Like it's freaking ridiculous. I'd drop an F-bomb right now, but I'm not among mixed company, and it's not after 5 and we're not drinking yet. But I would say the opioid crisis is the largest self-made medical crisis in world history. It's absolutely astonishing and ridiculous. And here's what's also not funny, but just also astonishing about the opioid crisis. Like everyone agrees we have an opioid crisis. Democrats, Republicans, you know, business people, people of faith, everyone knows these stats in some way in front of you right now, that the opioid crisis is absolutely ridiculous. Yet, if you die and if you were to die today and you're 40 years old or younger in America, the #1 cause of death is overdose by opioid. So you know, think about the disconnect here. And by the way, the experts you just heard from, some of the data they have on this it's not overwhelming and conclusive. It's completely 100% definitive. Like there's no arguing with it. So then, yet you still have an opioid crisis, right? And it was before COVID-19 that we were really ignoring this issue at some level. Really, I'd say in 2019, in my opinion, was the first time the crisis even made the headlines in an appropriate way. So next slide, please. But I also want to emphasize that COVID-19 has completely magnified the mental health, substance use and abuse, and overdose crisis. I believe that the simple way of looking at this is that as COVID-19, the virus, begins to subside, and when I say subside, I don't know if that's the next few weeks or the next 6 months or the next 12 months. At some point, we will have a vaccine. At some point, we will have therapeutics. We don't know when, but most scientists agree we're in the window, 6 months, 12 months, and society's going to remain disrupted until then. But I would tell you, as we see the medical emphasis of COVID-19 begin to subside, what I believe we're going to see is a mental health crisis, the likes of which we've never seen in America or in modern civilization. As a behavioral health specialist, Dr. Phil Toll shared with me, he's the chief behavioral health specialist for Aspire. They're the group that takes people on who don't have insurance. He said, Andre, we've never locked down society before in human history. Not to say that that was a mistake, but we've never done it. And so this is an experiment in that I think the results are whether we should or shouldn't have done it. In no way am I'm saying that. I'll let historians figure that fact out. What I'm saying is we have a mental health crisis, a substance use and abuse crisis, and an overdose crisis, the likes of which we've never seen before. And we had that before COVID-19, and COVID-19 has magnified it. So obviously leaders know this, and they just figure it out, right? They just solve it. Not really. For whatever reason, that's not how we operate in America. So Project Opioid, next slide, please, is about bringing together a slice of America that's not normally involved in issues like the opioid crisis and getting them educated, turning on them their own belief system at times through that education, and then getting those folks pointed at making real change to a crisis like the opioid crisis. So what we do is we go in and we build a coalition of the type of people that could actually do something incredibly meaningful and transformational. And oftentimes, folks, that's the people that we don't figure out how to get involved. If you're someone out there, I've only got a couple minutes, but I'll say a few things to you that you might not hear other places. If you're someone out there and you're listening to this and you're like, I'm going to make a change with my life and I'm going to be a change agent. Let me tell you something. If all you know how to do is talk to people in your bubble, that's not going to ever happen. If all you know how to do is talk to people that speak your polarized language, because our entire country is polarized, then that's not going to happen. Project Opioid is about bringing all different types of leaders together who often speak different cultural languages, different political languages, have different beliefs, and merging them together in a common direction around something that everyone agrees, like the opioid crisis, needs to be fixed. And so that's a real important part of this is us learning how, if you're going to be a change agent, to impact the people that aren't normally involved with this. And who, by the way, not only are they not normally involved, they're normally freaking wrong. They're normally wrong. They're like, yeah, these people who struggle with drugs, they're just making bad choices. And if you have mental illness, you probably did something bad to bring that on. And, we don't want to spend money on that because you're encouraging the problem. That's where a lot of leaders that we work with start. But our goal is to transform the way they think about this issue so that they can work on the solution. Next slide, please. So that's often targeting business leaders, faith leaders, philanthropic leaders, and trying to create a new front line to actually make solutions happen. Next slide, please. This is a group of some of the leaders we're working with right now. We built this coalition starting about 18 months ago. Some good folks here that can make a big difference. Next slide, please. So how can a leader make an impact on the opioid crisis? We believe the solution is aligning powerful people, like I just mentioned, creating education and awareness among top leaders who don't understand this issue. I like to take data like the kind of data we just heard that's so important, and I like to weaponize it. And how do you weaponize data? You weaponize it by pointing it at people who need to do something different and putting it in the media. So I'm all about weaponizing data that doesn't that doesn't have the ability to have its day in the public, I think is a missed opportunity. So we use data, but we weaponize it and get it out in the public in a way that's meaningful. And then, what are the solutions? What are the real solutions to the opioid crisis, and how do we coordinate? Imagine how many people are working on this issue and don't even talk to each other. So next slide, please. And so what does success look like? Next slide. Success for us looks like folks working together around Florida. This is a photo that I'm nostalgic of. Look, actual people in a room. Like, it's funny, you can date any photo you see now by like humans together or not together. So this is us in 2019 with a room of business leaders, who sit in the chairs in front of me when they start and have all the biases. They have all of the misconceptions. A lot of them do. And our job is to say to them, look, let us show you what this opioid crisis really is all about. Let's talk about mental health in a way you maybe haven't talked about before. And even, by the way, just one other little side note, something you won't hear a lot of out there. So I want to say this to you. If you're out there and you're 30 years old or younger, you're probably not religious. And I don't care if you're religious or not. That don't mean two shits to me. So I'll just prove it by using a cuss word right now. But what I will say to you is that 70% of folks who are like 40 and up are religious. So the reason that's important is because the whole religion, Judeo-Christianity especially, which is 80+% of Americans, you can use that to shape public policy for older folks by saying to them, oh, by the way, if the data says these folks are struggling and it's not their fault, how do you live your faith and not help these people? So I'm all about, guys, this is America. We can't force people to do anything. We have to take people where they're at and turn what they believe towards the truth through the lens they see it under. I'll give you another example of this. We are working right now, as we've done on homelessness, to make the economic case for solving the mental health, substance use and abuse, and opioid crisis. In my opinion, even if you don't care about this crisis, it's cheaper to help someone get medications like buprenorphine. It's so much cheaper to give that person buprenorphine than to send them through endless programs, that 12-step programs that often don't work. If you can show business leaders and other politicians that there's an economic case to be made as well as a moral case, that's again what we do if we're really trying to help people in need. Next slide, please. And Kendall just texted me and said I shouldn't have cussed, but I have to cuss at least once. It's my rule. And I appreciate your time. If you want to make change, last thing I'll say, and we'll open up to questions, you got to get the data, you got to get all the facts, and then you got to learn how to be someone that can work. You got to be able to compete in the arena of ideas and in a structure of leadership in your community, your state, and your country. And if you can do those things and bring them together, we can really help a lot of people. So that's what Project Opioid is all about.
Thank you so much, Andre. I'm not so mad about it. You need some passion in all of this. What a great session, just to have the research behind it with Dr. Andraka Masha and with Dr. Koval, and then of course with Andre Bailey. Super, super great. We don't have any questions, which is awesome because we are out of time. You guys gave so much great information. Thank you, panelists, for coming. Thank you to all of our participants. I'm going to have all of this information is live on our YouTube. So sorry, Andre, your little slip up is going to be public.
That's all right. I've said a lot worse.
Exactly. But it's still super great. This will all be accessible. And then of course we do have 2 more of our webinars. We're talking the global health management conversation this evening at 6 p.m. if you want to join and sign up for that. And then next week we're having a collaborative session talking about health law, and health policy, and how all of those things cultivate together. We'll go ahead, go to the next slide, Rachel, for me, the last one. This is our contact information and our social media, so you can follow us and come to these other webinars, and you can also get the information for Andre Bailey and the organization that he's working with, and you can get involved with Project Opioid. Again, thank you everybody for joining. If you want to reach out to us, go ahead, and we'll see you next time.
Bye.
Bye now.
Bye, thank you.